Welcome to the deep dive. Today we're jumping into the pretty complex world of treating Parkinson's disease. We'll be focusing specifically on the medications.
That's right. We've got some great information here outlining the different drugs, and our aim is really to unpack how they work.
Exactly. What are the strategies? Because at its heart, Parkinson's involves the loss of specific brain cells, right? The ones making dopamine.
Precisely. You lose those dopamine-producing neurons, and it creates this imbalance. You end up with relatively overactive acetylcholine signaling.
Okay, so the treatments are all about trying to fix that imbalance.
Fundamentally, yes, either by boosting dopamine levels or activity, or by, reducing that excessive acetylcholine effect.
And the sources we're looking at today really hone in on the pharmaceutical side of things.
They do. So we'll be walking through the main classes of drugs, how they function, and why they're used.
Right. So given that range of options, where should we start? What's the sort of cornerstone?
I think we have to start with levodopa and carbidopa. It's really the foundation.
Okay, levodopa and carbidopa. Most people have probably heard of these. What's their specific job?
So levodopa is basically raw material for dopamine. It's a precursor. The really clever part is that it can cross the blood-brain barrier, which dopamine itself can't do.
Ah, okay. So it gets into the brain.
Exactly. Once it's inside, the neurons that are still working can convert it into dopamine, directly replacing some of what's missing.
Makes sense. But why is carbidopa always paired with it? What does it add?
Carbidopa is crucial. Without it, a lot of that levodopa would get converted into dopamine outside the brain, in the rest of the body.
And that would be bad.
Yeah, that causes side effects. Things like nausea, sometimes low blood pressure or heart rhythm issues. Carbidopa inhibits the enzyme responsible for that conversion, dopamine decarboxylase.
Okay.
But here's the key. Carbidopa doesn't cross the blood-brain barrier, so it only stops the conversion peripherally outside the brain.
Ah, so it's like a bodyguard for levodopa, making sure it gets to the brain intact. Yeah.
That's a great way to put it. It maximizes the amount of levodopa reaching the brain and minimizes those unwanted side effects elsewhere.
I see. And that's why this combination is considered, well, the gold standard.
Pretty much. It's still the most effective treatment we have for directly tackling that dopamine shortage and improving the main motor symptoms, the tremor, stiffness, slowness, especially helpful in the earlier stages.
But it's not perfect. I've heard its effects can lessen over time, and this on-off issue comes up.
That's the major limitation, yeah. As the disease progresses, you lose more dopamine neurons, so there's less capacity to convert the levodopa.
Okay.
And levodopa itself has a pretty short half-life, maybe only 1 or 2 hours. This leads to swings in dopamine levels.
So on times when the meds work and off times when symptoms come back suddenly.
Exactly, that fluctuation. It's also because taking a pill gives you these pulses of dopamine, which isn't how the brain normally gets it. It's usually a steadier release.
That sounds really disruptive. Are there things people need to know when taking it? Practical tips?
Definitely. Big one is protein. Eating high-protein meals can interfere with levodopa absorption in the gut.
So take it on an empty stomach, impossible.
Generally, yes, or away from protein-heavy meals. Also, certain drug interactions are critical. You absolutely cannot take it with non-selective MAO inhibitors.
Why is that?
Big risk of a hypertensive crisis, dangerously high blood pressure. And antipsychotic drugs often block dopamine receptors, so they can work against levodopa.
Okay. Anything else?
Interestingly, high doses of vitamin B6, pyridoxine, can actually speed up levodopa breakdown before it gets to the brain. Less of an issue with carbidopa present, but still noted.
Wow, lots to juggle.
Yeah.
The analogy we saw levodopa as fuel, carbidopa as the funnel, really clicks now. It guides the fuel where it needs to go.
It's a good visual, yeah.
Okay, so that's the main player. What comes next? What other ways do we try to boost dopamine?
Well, another important class is the MAOB inhibitors. Think selegiline, rasagiline, safinamide.
MAOB inhibitors. What do they inhibit?
They block an enzyme called monoamine oxidase type B. MAOB specifically breaks down dopamine within the brain.
So if you block the enzyme,
You slow down the breakdown of dopamine that's already there or that's being made from levodopa, so it helps keep dopamine levels up. It's a dopamine sparing effect.
right, instead of adding more fuel, you're making the existing fuel last longer. Are there differences between those drugs you mentioned?
There are. Selegiline is an older one. It works, but it gets metabolized into amphetamine-like compounds.
Oh, does that cause issues?
It can sometimes lead to side effects like insomnia, yeah. Rasagiline is newer, generally more potent, and doesn't produce those metabolites. Safinamide is often used specifically with levodopa carbidopa.
And when would doctors use these? Are they a first-line treatment?
Sometimes they might be used alone very early on for mild symptoms. More often, though, they're added to levodopa.
Why add them?
Mainly to help with those wearing off periods to try and smooth out the fluctuations. They can help prolong the effect of each levodopa dose.
Okay. Any major side effects or things to watch out for?
Well, the insomnia with selegiline, as mentioned. At higher doses, they could raise blood pressure. Hallucinations are a possibility, like with many Parkinson's drugs.
What about that cheese effect you hear about with older MAOIs?
Ah, good point. With these selective MAOB inhibitors at the recommended doses for Parkinson's, that's generally not a concern. That effect, a dangerous blood pressure spike from eating certain foods like aged cheese, is more linked to the non-selective MAO inhibitors used for depression.
Got it. So safer in that regard. Any key interactions?
Yes, very important. Don't combine them with SSRI, antidepressants, or other MAOIs. There's a risk of serotonin syndrome, which can be serious.
Right, that interaction comes up a lot. The analogy for these was a dam, slowing the drainage of dopamine. That makes sense, preserving the supply.
Exactly.
Okay, next up in our sources, COMT inhibitors, entacapone and tolcapone. How do they work?
COMT inhibitors tackle another enzyme, catechol methyltransferase. This enzyme, COMT, is involved in breaking down levodopa itself, mostly outside the brain.
So wait, MAOB inhibitors work on dopamine in the brain, and COMT inhibitors work on levodopa outside the brain.
Primarily, yes, that's a good way to distinguish them. COMT breaks down levodopa into a compound called 3-O-methyl-dopa.
And that's bad.
It's not helpful, and worse, it can actually compete with levodopa to get across the blood-brain barrier. So by blocking
You
COMT,
stop that competitor from forming, and more levodopa makes it into the brain.
precisely, more levodopa gets to where it needs to be converted into dopamine.
So these would only ever be used with levodopa then?
Absolutely. They're always an add-on therapy, specifically used with levodopa-carbidopa, again, often to manage those wearing off periods.
Is one preferred over the other? Entacapone versus tolcapone.
Generally, entacapone is preferred now.
Why that?
Because tolcapone, while maybe slightly more potent as it works, both peripherally and centrally, carries a risk, albeit rare, of serious liver toxicity.
Oh, wow.
Yeah, so it requires regular liver function monitoring, which makes entacapone, with its better safety profile, the more common choice.
What about side effects for COMT inhibitors in general, similar to levodopa?
Often, yes. Because they increase levodopa levels, they can sometimes worsen levodopa side effects like nausea or dyskinesias, those involuntary movements. Hallucinations can also occur.
Any practical differences in taking them?
Entacapone has a shorter duration of action, so you typically need to take it with every dose of levodopa-carbidopa throughout the day. Tolcapone lasts longer.
Got it. The analogy here was a traffic cop clearing the path for levodopa. That fits well with stopping that competitor molecule.
It does, yeah, helping levodopa get through.
Okay, we've covered boosting supply and preventing breakdown. What about directly stimulating the dopamine receptors? That brings us to dopamine agonists, right? There's quite a list here. Bromocriptine, pramipexole, ropinirole, rhodogatine, apomorphine.
Yes, a different approach entirely. These drugs don't rely on being converted to dopamine. They directly bind to and activate dopamine receptors in the brain.
They mimic dopamine's action.
Exactly. They trick the brain into thinking dopamine is present and active. Like a stunt double, as one of the analogies put it.
I like that. So how do these different agonists vary? Bromocriptine, you mentioned, is older.
Right, bromocriptine is an ergot derivative, older class, works, but carries some specific risks we can touch on.
Okay. And the others? Pramipexole, ropinirole.
Those are newer, non-ergot agonists taken orally. You might also know them as treatments for restless legs syndrome.
Ah, right. And rhodogatine. That's a patch.
Yes, a transdermal patch. The idea is to provide steadier, more continuous drug delivery through the skin, potentially smoothing things out.
Apomorphine is different again. Injectable.
Very different. Apomorphine is a powerful, fast-acting injectable agonist. It's not for routine use, but as a sort of rescue therapy for sudden, severe off episodes when the oral meds just aren't kicking in.
I see. Like an emergency boost. So when are agonists typically used in treatment overall?
It varies. Sometimes, especially in younger patients, they might be used early on, partly to delay starting levodopa,
Why delay levodopa?
mostly to try and postpone the onset of motor complications like dyskinesias. which agonists are thought to have a lower risk of causing initially compared to levodopa.
Okay, and later in the disease.
Later on, they're often added to levodopa. This can allow the levodopa dose to be reduced, which might help manage fluctuations in dyskinesias, but it's worth noting they might not be quite as potent as levodopa for symptom control overall.
Right. What about side effects? Are they different from levodopa? You mentioned risks with bromocriptine.
Yes, bromocriptine being an ergot derivative has associations with things like vasospasm, confusion, hallucinations, and rarely serious issues like heart valve or lung fibrosis, so it's used much less often now.
And the non-ergot ones like pramipexole and ropinirole.
They can cause nausea, dizziness, or low blood pressure, hallucinations too. A key side effect to watch for is excessive daytime sleepiness, even sudden sleep attacks. Impulse control disorders are another potential issue.
Impulse control, like what?
Things like compulsive gambling, shopping, eating. It's a known, though not universal, side effect associated with agonists activating certain dopamine pathways. Needs careful monitoring.
Wow. So starting low and increasing slowly is important.
Absolutely crucial. Titrate slowly. And be aware of drug interactions, like ropinirole levels can be affected by drugs inhibiting the CYP1A2 enzyme, like the antidepressant fluvoxamine.
Okay, the stunt double analogy makes sense. They do the job, but maybe come with their own set of issues sometimes.
That sums it up well.
Now, for something described as quirky amantadine, an antiviral drug, how does that fit in?
Yeah, it's a bit of an odd one. Its benefits in Parkinson's were found somewhat accidentally after it was developed for influenza.
So how on earth does an antiviral help Parkinson's?
It seems to work through multiple channels. It's thought to perhaps increase dopamine release from remaining neurons, maybe block some acetylcholine activity, and importantly, it also seems to affect glutamate signaling by blocking NMDA receptors.
So it's doing several different things at once.
Apparently so. It's not entirely clear which action is most important for its effects in Parkinson's.
And what affects all those? What symptoms does it help with?
It generally provides mild symptomatic relief. It seems particularly helpful for reducing dyskinesias, those involuntary movements caused by levodopa. It can also help a bit with tremor and rigidity for some people.
But less potent than levodopa overall.
Definitely less potent for the core motor symptoms. And a key issue is that people often develop tolerance to its effects relatively quickly.
So its benefits might wear off.
Yeah, often it's more of a short-term fix or used specifically for managing dyskinesia rather than as a core long-term therapy.
Any side effects to be aware of?
It can cause things like dizziness, confusion, hallucinations, maybe some leg swelling, or a skin discoloration called levato reticularis. Dry mouth, too.
Okay. The analogy used was a multi-tool. That seems apt given the multiple mechanisms.
It does seem to hit several targets, yes.
All right, we're nearly through the list. Last
Yeah.
class mentioned antimuscarinic agents, benztropine, trihexyphenidyl. This takes us back to that acetylcholine imbalance, doesn't it?
Exactly. Remember how loss of dopamine leads to relative overactivity of acetylcholine? These drugs directly target that.
How?
They block muscarinic acetylcholine receptors in the brain. By blocking the action of acetylcholine, they aim to decrease that excitatory noise and help restore balance with the diminished dopamine system.
And which symptoms are they best for?
They are primarily used for tremor. They can also help a bit with rigidity. They tend to be more effective for tremor, particularly in younger patients where tremor might be the dominant symptom.
But again, probably not as effective overall as levodopa.
Correct. Less effective for bradykinesia, the slowness. And they come with their own set of side effects.
The anticholinergic side effects.
Yes. Things like dry mouth, blurred vision, constipation, urinary retention, and importantly, cognitive side effects, confusion, memory problems, even delirium.
That sounds like a particular concern for older patients.
Absolutely. They are generally used with great caution or avoided altogether in older adults because of that risk to cognition. Also contraindicated in people with glaucoma or prostate enlargement.
So turning down the acetylcholine noise, as the analogy went, but you have to be careful not to cause other problems.
Precisely. It's a balancing act.
So looking back across all these classes, levodopa, carbidopa, MAOB inhibitors, COMT inhibitors, agonists, amantadine, antimuscarinics, it really comes down to two main strategies, doesn't it?
Fundamentally, yes. Either find ways to increase dopamine function by supplying precursor, preventing breakdown, mimicking its action, or decrease the relative overactivity of acetylcholine.
And often treatments involve combining these strategies, like the example given, levodopa plus carbidopa plus entacapone.
Exactly. That combination hits multiple points. provides the fuel, levodopa, ensures it gets to the brain, carbidopa, and stops some breakdown along the way, entacapone, all to maximize dopamine delivery.
This has been, well, a really deep dive.
Hmm.
It shows just how intricate managing Parkinson's is. So many different ways to try and adjust that delicate brain chemistry.
It really is complex. And these medications, while often providing significant benefit and improving quality of life dramatically for many, they all come with trade-offs, side effects, interactions, the fact that the disease itself progresses.
Yeah, it's not a cure.
No, these manage symptoms, but understanding how they work based on the information we've discussed gives you a real appreciation for the rationale behind the treatment choices.
It definitely provides that foundation. And it leaves you thinking, doesn't it? Considering all these different targets, dopamine synthesis, breakdown, receptors, acetylcholine, even glutamate, what does that complexity tell us about just how incredibly interconnected everything in the brain is?
It highlights the immense challenge of treating neurodegenerative diseases, for sure.
And it really underscores the need for continued research, pushing towards maybe even more targeted or perhaps restorative therapies in the future, something definitely to ponder. Thanks for walking through all this with me.
My pleasure. It's a fascinating, though challenging area.